everyone, thanks for joining. We're going to get started now. Just a reminder, we have 30 minutes, one question, one follow-up. Today we have Dr. Williams and Dr. Yaffe here, so I'll turn it over to them for some remarks.
Okay, good afternoon. It's Monday, so it's our time to look back over the weekend, what has happened, and sort of look at what we're trying to see down the road for the week coming up. The last update, you had both updates from Dr. Heyer and Dr. Yaffe on Thursday, and then myself with Dr. Staney on Friday. So we'll give some updates there. So first, I'm going to hand the information that and updates over to Dr. Yaffe.
Thanks very much, and good afternoon, everyone. So, since the last update that Dr. Williams provided on Friday, Ontario has reported an additional 13,059 cases of COVID-19. If we break it down, on Saturday, there were 4,362 cases. On Sunday, 4,250. And today, 4,447. That brings our 7-day average of daily cases to 4,348. This is a 15% increase over last week's 7-day average, and a 58% increase over the average from 2 weeks ago. Ontario has reported over 4,000 daily new cases for 6 of the last 7 days. And sadly, we are reporting an additional 71 deaths since Friday's update. We extend our deepest sympathies to the families, friends, and caregivers of those who have passed away from COVID-19, and to all those mourning the death of a loved one in these very difficult times. Hospitalizations and intensive care unit occupancy are once again at their highest level since the beginning of the pandemic. Today, there are 2,202 people in hospital and 755 in ICU with COVID-19. In terms of testing, 42,873 tests were processed yesterday, with a positivity rate of 10.5%. That is the highest positivity rate we've seen since the pandemic began. Our current 7-day average for percent positivity is 8.8%. We now have a total of 36,894 cases that have variants of concern confirmed. The majority, 99% of these, are the B.1.1.7 variant, which was first identified in the United Kingdom. Our 7-day rolling average positivity for these variants of concern is 71.4% of our cases, and that is slightly up from 70.9% just 1 week ago. The words I said last week, that our situation is dire, they remain true today. The trends in key health indicators have deteriorated to levels far exceeding anything we have seen before. As noted last week, even with the stay-at-home order and the stronger public health measures in place, it will take some time before we see the effect of these interventions. But we do know that these measures work. We know that by reducing mobility, by staying home as much as possible, and by limiting social interactions to those within your household, our rates of transmission will begin to go down. I know that while these actions sound simple, simple isn't always easy to do. We've been at this for over a year, and it sometimes feels like there's no end in sight. But I know that we can all do this. We need everyone to do their part to allow more time for our vaccine plan to roll out. And when it is your turn to get vaccinated, please do so. It is critically important and key to controlling this pandemic in the long term. I'm going to now turn it back over to Dr. Williams for additional comments.
Okay, well, thank you, Dr. Yaffe, and I think those points about where we're at in the dire situation here with our numbers and our ICUs climbing and different patients coming in more critical and more serious right from the get-go is concerning as we try to put in all the measures that Dr. Yaffe's alluded to try and curtail or bend the curve, if you may, and to see if we can bring it under control in there. And I think part of that aspect there is that decreasing the mobility is a very critical one. And the idea behind strong measures is that the key part of that is strong adherence by the public to all those different components that Dr. Yaffe alluded to there. And by doing that, we can minimize and reduce and eliminate our exposure to those, to ones and others around with us, even the variants of concern. If we do that continuously, very carefully, and not lapse into periods of letting it go or becoming casual in that. The other aspect we're trying to really work on is the vaccination, and we've done more than 3.9 million doses of the COVID vaccine through Ontarians thus far. We hope to pass 4 million mark today, and that's a good milestone to get through as we head up from our mid 20% up to 30% of our population to be vaccinated. This is indeed a success, but we have more to go, a lot more to go, and we continue to work on that. So while we're working on getting the vaccine out, we need to do all else we can to keep the growth of the cases. That means those cases down. That means the percent of those get hospitalized and a percent of those into the ICU. It all has to be brought under control while we wait for the vaccines to impact more and more. And we've seen that effect, of course, in our long-term care homes and our retirement homes. And now we're seeing it in our age population groups that we brought down. But now we're trying to work that out, how to go into our high-risk areas and zones to do even more targeted vaccination in there. And we have a number of initiatives taking place, including vaccination at workplaces and other areas around where we understand there is high community transmission. And we undertake that. Last week, we heard the available data from Europe and from the United Kingdom, and Health Canada had announced that it no longer was restricting the use of AstraZeneca at any specific population at this time, so from 18 up at this time. So we've reviewed that situation here in Ontario and in concert with some of our other Chief Medical Officer Health across Canada while we wait for some final announcements from the National Advisory Committee on Immunization, which we hope to have some more further updates from them later this week, that we have ascertained, as a number of us had done, to move the age for the AstraZeneca vaccine after all review and carrying out the risk assessment down to age 40 and over, both at our pharmacy and our primary care settings across the province. And this is an important step to make it even more available because we're having more and more individuals in that 40 to 60 age group becoming quite ill and starting to fill up our intensive care units. And so we would really like to move at that, especially in high-risk population areas, that we would need to undertake that vaccination program. So with the supply of AstraZeneca available this time, the expansion of eligibility will also significantly give us better coverage in those hotspots and those communities there where our pharmacies are located and our primary care physicians have a very much working relationship with their communities in those jurisdictions. So I understand this change in this policy has been, and the narrative around that has eroded the public's trust and have made people somewhat hesitant. I think the thing I want to take away from that is that we want to be very careful always with these public vaccination programs. We want to look at any possibility of direction, even though there's a very rare event of this clotting disorder that here in Ontario we have a leading centre at the University in Hamilton, McMaster, and we are blessed by having that at our access, as well as the information diagnostic, and understanding that it is a rare event. So therefore, we want to make sure that we understand that and that you understand that, and you put that into perspective of the risk of COVID and the complications of COVID and other aspects, because everything has some risk to it, And the not doing it is even higher risk for areas, very high risk of complications of COVID. So we want to make sure we have that information for you as the consumer so that you're fully informed and not dealing with what you consider maybe possibilities or rumors, because you need to have the data, and we want to make sure that was available for you at this time. So with that, we will be coming out with more information material on that, so you have that available to you. And as a number have said, as a vaccine, it's very effective in that sense, safe, but we want to make sure that there is a slight risk, a very, very, very risk, but we're aware of it. Our medical community now is aware of what that is, and they can assess that very quickly and render investigations and treatment if in the rare case it does occur in that. So we're asking people, when your turn comes up or when you have an opportunity, do register, do go to your pharmacy, contact your primary care physician if they are giving vaccinations, and ensure that when your time comes to go forward and get vaccinated. Because by doing that, we hope to keep moving ourselves forward to get up over that 40% of our adult population vaccinated, if we can, as soon as possible in that aspect there. So we're looking at those measures that Dr. Yaffe alluded to: decreased mobility, more care around who you associate with, very limited to your family. All the measures we talked about before that have to be done and done well again, especially with these variants of concern that have very easy transmission with very short contact, and even with some people who deem themselves to be asymptomatic or not of exposure, you cannot be sure, unless it's in your household where you know the history of their exposure, that it's been as standard and stabilized as yours. So we ask that you would continue to do those things very much in these days ahead, so we can keep the load on our healthcare system down. You keep healthy, your family keeps healthy, and as you wait for your vaccination, and to add that to your protection. So those are comments today, and with that, we'll open up for questions from the media.
We'll go to the phone lines. Just a reminder, one question, one follow-up. Over to the first question, please.
From Jack Howard in Queensburg Briefing.
Hi there, Dr. Williams. I was just wondering if NACI tomorrow says that the AstraZeneca vaccine is safe or safe enough to outweigh the risks for everyone over 18. Is that something Ontario should move to expand the age eligibility right away?
I would certainly welcome that. What we were trying to look at is with the data from the UK, and we're trying to understand that area at 18 to 40 to get the metrics on that about how the risk benefit in that age group, because we haven't got a lot of cases here in Ontario in the 18 to 30 age group. We have some, especially with the use of AstraZeneca. We don't have any, so we have to look at those other jurisdictions. So I would like to get it down to 18. As soon as possible, but we'll have to wait to see what the full data analysis on that is. Even though Health Canada has cleared it down to 18, it's that risk of these different age groups as compared to getting COVID. As I said, we don't have a large number, fortunately, of people 18 to, say, 20, 25 that have COVID and have had consequences of that in that age group. So we're waiting for some further information on the wider lit research that some groups like NACI and others are doing to give us that information. So we would welcome that.
Follow-up?
Oh, thanks. And on a different topic, I was wondering about primary care physicians and vaccinating their patients. If a family doctor thinks that their patient should be a higher priority for the vaccine, are they able to essentially bump them up the wait list?
I think I got the gist. You're saying if they're seeing their primary care doctor and their primary care doctor feels they should be bumped up, as in, say they have a condition that should be in an older age group. You mean on the booking system, or do you mean in relation to AstraZeneca vaccine?
Sorry, with regards to the AstraZeneca vaccine.
Oh, well, the doctor who has seen them, say the person is concerned about maybe they've had some problem with blood clots or they're on various medications and that, I would advise them to discuss it with their family doctor, and that family doctor may say their recommendation may say, okay, I think AstraZeneca is fine. They may say, maybe using one of the others, maybe you should wait for it when your age group comes up. So we still will go with the primary care doctor's assessment, and that adds to that individual's risk assessment. If there is anything that's even with a preponderance of caution, they may say, because of the risk exposure in that, be very careful and let's wait for something different. We will accept the primary care doctor's recommendation in that regard.
Next question.
From Robert Ferguson with the Toronto Star.
Hi, Doctor. I'm wondering from a public health standpoint, do you think we need to be closing more non-essential workplaces and businesses? And feel free to answer yes or no.
I think there's always ones we're looking at, how we might do that and what the definition of essential is. And we're continually trying to understand how that impacts, and then, of course, what is necessary in there. So I can't give you a yes or no. I think we're always working that through with our various other sectors to understand how that works, and what some people may not think is essential, someone else says that is so essential, and the people want that service available to them. So it's not a clear-cut answer in some people's minds.
Follow up.
Okay, thanks, Doctor. And what is the? I'm wondering, what are the current rates of hospitalization and ICU admission? When I look at the daily epidemiologic summary, I see about, so far in the pandemic, about 1% of people, I think if I recall correctly, seem to be requiring ICU, and about 5% seem to be requiring hospital. But what are those rates now that we're in this acute stage of the third wave?
Well, that's a good question, and I'm asking those questions over to our critical care teams to look at the metrics of that. In the first wave, it was about 6% and 3%. So about 6% of the cases got hospitalized, and 3% of those ended up in the ICU. With the COVID that we had in the first and second wave. In the second wave, it changed a little bit. It dropped down from 6 to 5.5%, and the 3 moved down a little bit to about 2.5%. But with the data that we heard from some of the research done thus far, the evidence is that the rate of hospitalization was about 1.4, 1.5 that of the regular COVID. So that means it's higher percent. And the ICU admission rate was twice that in there. So it seems that the variants of concern have a higher hospitalization rate and a higher ICU rate. Now, we're continuing to be looking at that data as it progresses, and we have large numbers. So I'm asking our Ontario health experts and our analytic people to see what kind of granularity of that data. How is it changing and shifting with the variants of concern? And most of our variants at this time are the B1.1.7, that's the UK variant. We have a few of the others, so we're trying to understand as well and learn from our counterparts on the other part of the Canada and BC and Alberta as they deal with that variant, and what are they finding to advise us in that. So we're all sharing what we're learning in each of our respective jurisdictions.
Next question, and this will be the last question unless someone else joins the queue.
From Alexandre Chasson with CBC News.
Hi there. Thanks for taking my question. It's actually similar to one of the ones that was just recently asked by the last reporter. It's about essential workplaces, and I'm not sure I got a clear answer. I understand that you're saying there's not exactly a clear decision on that, but could you perhaps give us your medical opinion on whether the province should revisit what is deemed essential when it comes to workplaces? Are you saying that it's being looked at?
I think one of the aspects we've been really trying to work at is that these workplaces are undertaken and looked at with safety in mind. So what things, as compared to the first wave, that we've put in place with our Ministry of Labour inspectors, looking at different things that need to be in place about distancing, masking, sometimes with partitions in between workers and that, in order to maintain these essential, whether they're food processing plants that people require to get their food on their table, or there's some other things that need to be put together. Every time we have some areas, someone else identifies, well, that's essential and critical. Why can't we get that? So it's a combination of what can we do first to protect the workers in there, and what can we do as far as further inspections and do vaccination programs. So really trying to work at that now to say, can we go in, especially some of these larger centers that are doing essential work, and have them vaccinated, including maybe some of their family members as well, to try and protect that. But at the same time, we're asking those questions, are there some that we could close that wouldn't put people into a very sort of a dire strait? They have to go elsewhere to try and get what they consider essential products or materials. And so we trust our other people in those sectors to give us advice and discussions between our public health measures table and them, and there's those discussions are ongoing. It just seems it's a continuing as we learn more and understand more. So we're looking at them, and we will be advised by many people of what we might do, because we really want to protect those workers as best we can in those circumstances.
Follow up, and this is the last question.
Okay, so then, for example, like the best case scenario modeling that is presented to us is based on making the essential list as small as possible. Do you think that it is, or you're saying that it's in flux?
I would agree that we should try and make it as small as possible. Again, not compromising that people who need some essential materials are not missed out on. You can always close things for a short period, and some of those, if there's an outbreak, will be and have been closed for the period of time if there was an outbreak at some of those centers in there. So I think we would like if they're non-essential, then they should be closed. If they are essential by definition, then we'd have to look at the cost of closing those, and would that cause any harm to people who couldn't get something that was vitally necessary, say after a period of a week or so. So by definition, essential is essential, but we really look at the difference between when should be non-essential. And then in that case, then if you take one from essential to non-essential, you determine that those materials they supply out to the public are no longer necessary for that period of time. And that's something you'd like to be comprehensively informed on before you did that.
Thanks, everyone.